Thyroid disorders can occur, as you know, with or without diffuse or nodular enlargement of the gland. Symptoms may be due to pressure alone, or to hyperfunction, or to hypofunction. Whenever an isolated thyroid nodule is felt, not associated with hyperfunction or hypofunction, and especially if there is any change in size of the nodule, the possibility of neoplasm must be considered. It's some of the important considerations in diagnosis, histology, needle biopsy, scanning, and in treatment, radioiodine, antithyroid drugs, thyroidectomy, of hyperthyroidism and thyroiditis, nodular goiter, thyroid carcinoma, and hyperparathyroidism that occupy our attention in this issue of Audio Digest Surgery, Volume 18, Number 5, Disorders of the Thyroid and Parathyroids. Recorded at a recent Cleveland Clinic postgraduate course in general surgery, 50 Years of Surgical Progress, our session begins with a discussion of hyperthyroidism and thyroiditis by Penn G. Skillern of the clinic's Department of Endocrinology.
Over the years, it's been shown pretty clearly by United States National Statistics of Health that the death rate of hyperthyroidism went down significantly with the onset of the good thyroid surgeons, the ones who headed various centers throughout the country. But since radioiodine has taken over in the treatment of Graves' disease, the death rate has gone down even further. And I think that's because there was a significant death rate still with surgeons who did not do so many thyroidectomies for Graves' disease in the smaller communities, just there is in patients who have gastrectomies, total gastrectomies, or other more serious operations. And the death statistics in institutions like the Cleveland Clinic and the Mayo Clinic, Leahy's, Ochsner, all remain low over the years and still are very low. But it's not low out in the smaller communities. And I think that's why the national death rate from hyperthyroidism due to Graves is so sharply dropped, since we're treating almost all patients with Graves or radioiodine. The only patients that we would initially treat with antithyroid drugs are the patients who are pregnant. And then after their pregnancy is delivered and the mother's not nursing the baby, we give the patient radioiodine. Otherwise, the old rule of over 35 we treat with radioiodine, I think everybody agrees now that over 35 we treat with radioiodine. There are some differences still among institutions and investigators and people who have had a great deal of experience in patients under 35, but we now treat everybody, including children, with radioiodine, and have been for the last 15 years. For the first 10 years we piddled around with antithyroid drugs and we did some surgery, but I'm known as Joe Blitzflick at our clinic anyway. Every time I get a drug, I get the bad reaction. I had 2 patients with agranulocitosis, and one of them died at age 16, which shook me up more than anything I've had since I've been here, so I've never used antithyroid again for children. We've had no complications at all as far as vocal cord damage, parathyroid damage in our children. Dr. Schumacher and Dr. Crowell have continued to follow these children. We've had hypothyroidism develop, which develops at about the same incidence as patients who have surgical treatment for Graves, but the recurrence rate of hyperthyroidism is much less than it is after surgical treatment. Al Hales at the Mayo Clinic and Ollie, I know, still feel that surgical is a treatment of choice, not because of the hypothyroidism, but because of the fact that they still worry about genetic effects in carcinoma, thyroid, leukemia, and things like that. But we have had no such complication. I don't think there will be any at this age. We don't see children under age 5 with hyperthyroidism. Maybe we've seen 1 or 2 over the years. And I suppose perhaps you could sort of delay radioiodine treatment if they were extremely young with antithyroids, but they're so rare that we're talking about mostly children between 5 and adolescents. I think after adolescence we call them adults. Radioiodine treatment requires a certain amount of skill, believe it or not. We do have several types of approaches. We have what we in our profession call the medical piddlers. They piddle with little doses of radioiodine, and patients get so sick of having hyperthyroidism for 6 to 12 months that they go to the surgeon and get a definitive result, which I don't blame them for. There is no way that we believe that you can cut down the incidence of hypothyroidism. This is the purpose of medical piddling with radioiodine. The theory is to give smaller doses, or if you give iodides with it, or if you give antithyroid drugs, you may be able to give smaller doses. But the trouble with this, and if you ever read any of the reports that have been published on this, is that so many of them get recurrence of hyperthyroidism and they get discouraged and disgusted. And there's no good evidence, in my opinion, that you're going to cut down the incidence of hypothyroidism. It's been clearly shown by work at Mayo's and other institutions that the incidence of hypothyroidism 10 years after surgery varies from 35 to 55%. And it wasn't until a medical man at the University of Michigan said, well, let's look at the surgeon's results. They're always saying that we have so much radioiodine-induced hypothyroidism. Let's see what they have after their surgery. And this was found to be about 40%, 45% in their own institution within 10 years. So there's a natural incidence of hypothyroidism developing in surgically treated patients, which I think is the same thing that occurs in at least a certain amount of our radioiodine-treated patients, probably due to the presence of Hashimoto's thyroiditis. Dr. Beers and other men at the Mayo Clinic in that paper that they wrote showed that there's about a 25% incidence of Hashimoto's thyroiditis initially in patients who have Graves' disease treated surgically. So I think this is a significant factor as to why there is a high incidence of hypothyroidism in both patients treated with radioiodine and surgically. I think the other factor that has been shown by Gerald Burke in Chicago is that as the years go by on patients who've been treated with Graves' disease with surgery, the Hashimoto's incidence increases. Or for some reason that we don't understand, the cells undergo failure. And they develop increasing incidence of hypothyroidism at about the same rate as the patients who have radioiodine treatment develop it, about 2% a year. I'm sure that we have this factor of variation in sensitivity to tissues to radiation. We have this factor of not knowing exactly what dosage to give the patients that cause a certain number of patients who are treated with radioiodine to develop hypothyroidism. We've devised what we think is a really simple solution. We used to have patients come back every year after radioiodine treatment, which is what they say in most institutions. The only trouble is that practical situation at the Cleveland Clinic, the Mayo Clinic, is that most of the patients don't come back every year. They might if they're sitting in Tulsa, Oklahoma, and that's where they had their treatment, but they don't come back to us. And secondly, they might come back in January and look fine, and by June get hypothyroid and stumble in next January with hypothyroidism for 6 months that they didn't recognize. So we adopted the policy about 5 years ago of giving every patient who's treated either with surgical treatment or with radioiodine treatment thyroid hormone. We give 2 grains of Armour's desiccated thyroid or 0.2 milligram of L-thyroxine, either the Armour's letter or the Synthroid, and give that to them the rest of their life right after surgery or radioiodine treatment. We hardly do any surgery anymore, but I think it's just as important to do it for surgically treated patients as it is for radioiodine treated patients. We tell the patient that they are to take this thyroid permanently. We give them a letter, a copy of the letter that we send to the doctor. If we're not sending one to the doctor, I send a letter to them, what treatment they had here, what we found, what their follow-up showed, and make a big case out of it. And we followed up patients for 3 years, 100 patients that we did the first 3 years, and found out that 2 of them quit taking thyroid, and both of them, the doctor stopped it. They didn't quit it themselves. So this is the problem. It isn't the patient quitting it, it's the doctor stopping it. And by giving them this letter, we've found that we've been able to circumvent that. They don't need to have thyroid checks anymore. If they take the thyroid, they don't need to worry at all about developing underactive thyroid. About 1 out of 200 after radioiodine treatment develops hypothyroidism for Graves' disease, and with surgery it varies from how total a thyroidectomy you do, from, as you know, from 2 or 3% recurrence rate to 10% recurrence rate. So the recurrence rate after radioiodine treatment is much less than after surgical treatment. And this is an advantage because for every 99 patients that come back and think they have recurrence, I find one that has a true recurrence. Those other 99 have anxiety tension state symptoms. So I think that this is another distinct advantage of radioiodine. It's been safe. A national study that was done through the National Institutes of Health confirmed what already has been found in England and by large institutions such as ourselves, that there is no increased incidence of leukemia, there is no increased incidence of cancer in the thyroid or elsewhere. We still don't know the genetic effects, but most of the physicists that I've talked to tell me they never did worry about this as far as radioiodine for patients for Graves' disease, because we use such small amounts and it's in the system so transiently. I think with large doses that we use for hyperfunctioning adenoma, if they were in young people, it would be different, but we're not using them in young people. We're using them in older people mostly who have hyperfunctioning adenoma. The cost of radioiodine treatment has remained pretty much the same. We charge $200 for the test and treatment. 9 out of 10 patients are well within 2 months. We don't piddle. We give what we think clinically the patient needs. We have a formula that we use, but the formula really doesn't mean much. We give about 150 to 200 microcuries per gram. We estimate the weight of the gland, say it's 50 grams, 100 grams, we give 100 microcuries per gram, and then we multiply by 100% because we're dividing by the uptake percent. It really doesn't matter because most of our patients get 10 millicuries, and if I see the patient looks pretty sick, I'll give them 15 or even 16. Or if they got a bigger goiter than the standard size, we'll give them 15, 16 millicuries of radioiodine because we find that with the big goiters they're more resistant to radioiodine than with the small goiters with Graves' disease. But if one gives adequate dosage, one can be sure that you're going to get the patient well rather than piddling quickly. Now, occasionally we see a patient that's very ill that comes in, and by ill I don't mean jumping around a lot, I mean wasted, weak, anorexic, nausea, so weak they can hardly get off their chair. In which case we don't treat them necessarily with radioiodine. Initially we try to get them well more quickly in better shape, and so we will usually put these patients in the hospital. We'll give them saturated solution of potassium iodide, 5 drops twice a day in water. We use this now instead of Lugol because Lugol upsets too many people's stomach, and it has more iodide in it anyway. And it works more quickly, and it's been shown pretty definitely now that iodide does block the release of thyroxine. It doesn't block the synthesis of thyroxine. It blocks the release of thyroxine, some work that was recently published in Boston. So that it is effective more quickly than antithyroid drugs, which block the synthesis of thyroxine, but take 2 to 4 weeks to really work satisfactorily. But we do start both simultaneously. More recently, we've been slipping the patient radioiodine and then following it with iodide and antithyroid. We're a little hesitant to do it before because we thought we'd precipitate crisis, but we now know that it doesn't make much difference. We don't precipitate crisis by giving radioiodine. We precipitated crisis in the past by stopping antithyroid drugs in patients. That's where we got our crisis, and getting them ready to give them radioiodine. So a patient is pretty sick. We don't stop the antithyroid very long. All we do is just stop it for a day or 2, and then give them the radioiodine treatment and put them right on antithyroid. In about 2 days afterwards, we give them the antithyroid drugs again if they come in this way. I'd like to go into the treatment of thyroiditis to give you a little better understanding of the new classification developed by the Pathologist Committee of the American Thyroid Association. We now call it really lymphocytic thyroiditis with a diffuse form, goitrous. We have different variants. We have an early phase which is mostly hypercellular with lymphocytes and round cells, but very little fibrosis, although there is some. This is always asymptomatic. This is the kind that Dr. Hazard first described. Hashimoto didn't see this. And then we have Hashimoto's variant, or the oxyphilic variant, where they have hyperplasia and hypertrophy of the follicles with hypertrophy of the cell. They have more pink staining change. Obviously, something's going on in the cytoplasm. Then we have the late phase, which is a fibrous variant. This is the patients that are more apt to have the very hard goiter. These are the patients that are always hypothyroid, sometimes hypothyroid, and always euthyroid. Usually in younger people, we see this variant. And we have the non-goitrous variant, mild atrophic, usually asymptomatic and severe atrophic. What we call primary hypothyroidism without goiter is now classed as a clinical variant of diffuse lymphocytic thyroiditis or lymphocytic thyroiditis. So the two are clinically related, pathologically related, and act very much in the same way. Then we have what we call focal lymphocytic thyroiditis, which is seen in association with other diseases. Hashimoto's thyroiditis. We give 3 grains of Armour thyroid or 3/10 milligrams of Synthroid to decrease the size of the goiter to normal. But if it has a lot of fibrosis, we just give them 2 grains or 2/10 milligrams and forget about it. And this is lifetime treatment. We give them a letter, what they had, and certify the diagnosis so that nobody again will stop the thyroid. Treatment for subacute granulomatous thyroiditis, we believe that corticoids are the treatment of choice. And to give you a little simple rule, we give 5 milligrams of prednisone, which is inexpensive, 4 times a day for 4 days, 5 milligrams 3 times a day for 3 days, and then for the rest of the time we give 5 milligrams twice a day. One of our problems is we didn't know how long to give it. We'd give it a month. That's what we would do, and then we'd stop it. And then we'd find that half the patients, 2/3, would get it back again. So we'd give it another month and stop it. But more recently, a paper that was published in the Journal of Clinical Endocrinology suggests that one way to tell how long to give it is to do a tracer about every month. If the tracer shows that the uptake goes from very low value up to a normal value, then you know you can stop the corticoids because the patient's thyroid is now returned to normal. I think that's a pretty good rule of thumb. or else you can just give it 2 months and quit and see what happens, and follow another month if tracers aren't available to you.
Thank you, Dr. Skillern. Our next topic, nodular goiter. As Oliver H. Beers of the Mayo Clinic and Mayo Foundation outlines the indications for medical versus surgical therapy in this condition.
Nodular goiter remains a controversy, I think, in the minds of many, because it's perfectly obvious today that there are multiple modalities in the management of thyroid goiter, and there are medical treatments available for goiter which in the past and today can be satisfactorily and safely managed by thyroid surgery still. One might wonder whether or not there's going to be any place for the surgeon in the future in the management of thyroid conditions, and I guess I would say at this stage of the game that very likely the surgeon will go out of the thyroid business in the future. I think it's obvious from the statistics that already have been mentioned that the surgeon is taking a smaller and smaller place in the management of patients with thyroid conditions. Certainly the toxic goiter has almost been entirely taken over by the internist with the use of radioactive iodine. There are several holdouts where surgery still remains the primary treatment of management, but this is not proving to be true in many areas. As far as nodular goiter, I think now that we recognize the differences in the biologic behavior of the various types of cancer, becomes less and less of a surgical problem, and as a result, the physician and surgeon can be more and more selective in deciding which goiter, based on clinical and laboratory grounds, needs to be removed. However, there are some goiters today that I think we would all agree remain a surgical problem. In discussing the goiters that are a surgical problem, I think it's only right to say that we should think of the potential hazards and not necessarily talk about one sole hazard. For instance, we don't see large goiters very often any longer. Matter of fact, they're rare. However, cosmetic deformity remains a problem for a few patients. So, a goiter of this type, I think, is by far best treated surgically. Hyperthyroidism, at one time by Dr. Rynearson, was said to occur probably in 50% of patients with multiple adenomatous goiter. I think this is excessively high. Probably 10% would be a more reasonable figure. And today, seeing fewer and fewer nodular goiters and fewer large multinodular goiters, the instance of hyperthyroidism is not too common. However, I think when hyperthyroidism does occur, as Dr. Skillern already has emphasized, it probably remains a surgical problem and the goiter is best removed. Now, in addition to hyperthyroidism, pressure symptoms in the neck certainly are an indication for surgical treatment. Some of these goiters fill the thoracic inlet, causing pressure not only on the blood vessels of the thoracic inlet, but also on the airway, and certainly for relief of symptoms, the goiter is best removed surgically. Also, other structures can be deviation of the esophagus, resulting in dysphagia. This goiter naturally is best removed. Likewise, a goiter can become a substernal mass, creating a differential diagnosis because of its own unknown nature, in addition to causing symptoms that I've already mentioned. And goiters of this type should be removed, and most of them can be removed through the cervical approach. However, occasionally it's necessary to go through the thoracic approach, and this is done at an increased mortality and morbidity. Now then, coming to the multiple nodular goiters, what is the risk of cancer existing in a nodular goiter, and I think this is one of the controversial points that we must consider in selecting those goiters that should be removed. This situation occurs undoubtedly in less than 1% of instances. I think one must acknowledge the fact that almost all of these cancers are papillary in type. In dealing with papillary adenocarcinoma of the thyroid gland and knowing its biologic behavior, one could almost take the position that this goiter need not be removed because of this potential hazard of a cancer in less than 1%. A patient such as this with a lesion like that would probably live for 30 or 40 years without dying from that lesion. On that basis, one might say that for the large multiple adenomatous goiter, it need not be removed because of this risk of cancer. Now then, the problem which is more real is the presence of a discrete nodule in the thyroid gland, which on clinical grounds is suspected of being a cancer, but yet one is uncertain whether it is or isn't. I think one can undertake prophylactic surgery, thyroidectomy, because of this potential hazard only if the surgical experience reveals that the operation is a very safe one to carry out with a mortality rate essentially of 0 and a morbidity rate very, very low. And what should an acceptable morbidity rate be? Naturally, a 0 morbidity rate would be best. But I think doing a sufficient number of thyroidectomies, one does expose the patient to a small risk. And currently at our institution, the risk of tetany in the primary case in which a subtotal thyroidectomy is done is 0.3%. That's one case in 300. This is a serious complication, and I think we must acknowledge its occurrence because in treating some types of cancer of the thyroid gland and other benign goiters of the thyroid gland, the problem of tetany can be as serious in the future management of that patient as the condition for which the operation was carried out. The incidence of cord paralysis should be 0, but again, it isn't. Unfortunately, it runs about 1%. Currently, 0.6% at our institution, unilateral cord paralysis. No instance of bilateral cord paralysis, except in those cases where, with intent, both nerves were sacrificed. Well, this might be an acceptable morbidity, but yet even 1 in 100 is too much, because this is a problem for that one patient, and certainly your medical colleagues always remember that one case and will remind you of it when the decision is faced as to whether or not a particular goiter should be removed. Now then, as far as some of the benign types of goiters are concerned, Hashimoto's thyroiditis. I think we all recognize today that Hashimoto's thyroiditis primarily is a medical problem and can be treated as a medical problem. But yet in our experience, 18 cases and 605 cases previously treated by surgery proved to have a papillary cancer in the goiter. Therefore, any Hashimoto's thyroiditis treated medically that does not spontaneously disappear in 3 to 6 months must be considered for surgery. Likewise, lymphosarcoma will occur in a gland otherwise containing Hashimoto's thyroiditis in about 3% of cases, and for this reason, this must be kept in mind, and again, if the goiter doesn't disappear or if a distinct or discrete nodule occurs, the lesion should be removed. As far as subacute thyroiditis, as Dr. Skillern already has implied, this is a medical problem. But unfortunately, about a third of these cases will not have the typical clinical symptoms of this type of thyroiditis. So occasionally, a lesion that is localized, even though undoubtedly it'll become progressive, is confused clinically with a cancer, therefore it should be removed. Riedel struma occurring very infrequently, today about once in 1,000 cases, and when it does occur, because of its firm character, its constriction about the trachea, remains a surgical problem, but again, very rarely seen. Now, any goiter that is suspected of being Hashimoto's thyroiditis, we would prefer to obtain a needle biopsy. Today, we are still, for the most part, using needle biopsy only for those goiters suspected of being Hashimoto's thyroiditis. However, we do use it for certain benign goiters merely to establish the fact that this is a benign colloid lesion, occasionally for an iodide goiter, or for a goiter suspected of being one of the other types of thyroiditis. However, we do not use needle biopsy for any lesion which is being considered for surgery because of the suspected diagnosis of cancer. The scan is a tool which is of great value, but one must remember that this is not all-inclusive. Generally speaking, thyroid cancers, 60% in our experience are cold nodules, 34% the scans are inconclusive, and in 6% there is evidence of increased uptake in the region of the goiter. Thyroid cancer, the occult papillary cancer, has an excellent survival over 40 years, essentially that of the normal population. But all of these lesions, left alone long enough, will fall into the extrathyroidal cancers where patients do die of this lesion. Therefore, papillary cancer, we feel, should be treated. As far as the follicular cancer, when they become invasive, the prognosis then drops below the normal expected survival rate. Therefore, this type of cancer should be treated, and certainly the medullary cancer likewise should be, because of its spread to regional nodes, and naturally the anaplastic cancer drops in that manner because of its rapid growth, and all patients die from it. Now, you might think from the comments that I've made that we feel essentially all goiters should be removed for the reasons that I've given. But I think it's also obvious that this is not true. From our standpoint, a goiter occurring in a young person that is recently new or discovered, that is discrete, that is firm, that is suspected of being a cancer, would be removed under any circumstance. Any goiter in an older person that is multicentric, that is relatively soft, that has been present for many years, that has not changed in recent months, undoubtedly would be observed. Generally speaking, today, we are operating on less than 10% of patients that have nodular goiter that we see. 90%, in other words, are either observed or treated medically. There is a large gray zone in between the two extremes that I mentioned that still remain somewhat controversial as far as management. Nevertheless, I think with the aids that we have available today and in the future, we're going to be much more selective in picking out the patient that should be treated medically and surgically or observed alone.
Thank you, Dr. Beers. And this, Doctor, signals the end of Side A of this program. Side B, with discussions on thyroid carcinoma, technique of thyroidectomy, and hyperparathyroidism, can be heard by just flipping over your recorder's cassette or 2 reels. Side B, Audio Digest Surgery, Volume 18, Number 5, continues a program on disorders of the thyroid and parathyroids. Next on the program, the Cleveland Clinic's William A. Hawk of the Department of Pathology and George Kreil, Jr. of the Department of General Surgery discussing thyroid carcinoma. Dr. Hawk is first at the microphone as he details the classification and natural history of thyroid carcinoma.
The classification of thyroid carcinoma, which I propose to present to you today, is that which has been agreed on by the American Thyroid Association. Now, I realize that pathologists may not know what lesions are, but they can always give them a name and always put them in a pigeonhole. But this is one time, I think, where a very meaningful clinical pathologic correlation and classification has been made, and I think it's absolutely essential for the proper therapy of thyroidal carcinomas. We start with papillary carcinoma, we come to follicular carcinoma, medullary anaplastic. The incidence of the various types, certainly papillary far outnumbers all the rest. The folliculars comprising 20%, medullary 5%, and anaplastic 10%. These are figures which are in close agreement with the Mayo Clinic group as well as our own. Now, starting off with papillary carcinoma of the thyroid, the usual papillary carcinoma, which presents no difficulty in classification, is one which has all of these papillary projections. They have well-defined fibrovascular cores, and they are covered by a rather characteristic cuboidal epithelium. However, there are a number of other very well-differentiated follicular structures which do contain varying amounts of colloid. I would add that the presence of colloid has not seemed to correlate particularly well with radioactive ion uptake, at least judged on the basis of its histologic appearance. Now, if we look at these follicular structures, we notice that many of these cells have rather clear nuclei. And Dr. Hazard gave the name Orphanani nuclei to this type of epithelium. And this is the important thing in making the diagnosis of papillary carcinoma, is to identify the epithelium and pay relatively little attention to its architectural configuration. That is, whether it is in a follicle or in a papillary projection. Papillary carcinomas can be almost entirely follicular, and you may take as many as 20 blocks before you will find one papillary signature. Now, in patients who are 55 years of age or over, we observe in some of these papillary tumors the so-called tall cell variant. And this does not share the excellent prognosis that the tumors which have the cuboidal epithelium with the Orphanani nuclei do. And this produces large, bulky tumors. Fortunately, it's rare. And the thing to remember is this is the tumor associated with the older age people. It is much less susceptible to suppression by desiccated thyroid therapy, which is a hallmark of papillary carcinoma in the younger age groups. Now, follicular carcinoma occurs in two forms. One which is rather a good actor, and one which is a very bad actor, the invasive. Encapsulated angioinvasive follicular carcinoma appears somewhat different than the usual semi-translucent tannish adenoma that we see every day, but one may not see evidence of gross angioinvasion, and multiple blocks have to be taken around the perimeter of this capsule in order to demonstrate angioinvasion. I have not, in the 20 years that I have been here, seen angioinvasion which could be grossly determined. Capsulated angioinvasive carcinomas, in only 2% of the cases seen here, have given rise to cervical lymph nodal metastases. But when they do metastasize, this particular tumor will go to lung and to bone. The importance, I believe, in making the distinction of these encapsulated angioinvasives is that prophylactic radical neck dissections of any type really have very little to offer these patients, because this is a tumor which is not going to metastasize to the lymph nodes anyway. Now, the invasive follicular carcinomas, on the other hand, are not encapsulated. They involve usually an entire or nearly an entire thyroidal lobe. Very many of these certainly have no such evidence that they have arisen in an antecedent or pre-existing adenoma. Nor is there any evidence in studying many of these cases that the encapsulated angioinvasives give rise to lesions of this type. One characteristic is rather fluted appearance that one sees in the cross-section. When you see this, this is a good indication that this may be a follicular carcinoma. Now, another type of carcinoma, which is of some interest to us, is the so-called medullary or solid. One of the problems and objections to the term medullary has been that it implies softness, and these tumors are extraordinarily hard. I would call your attention to the fact, however, that they have a rather characteristic cut surface appearance of being rather dry and waxy. The tumor usually is white to pinkish white and gray, sometimes with areas of hemorrhage. The medullary carcinomas are formed of a rather uniform type of epithelium, which we call undifferentiated. They are thought to arise from parafollicular cells. I must admit that I have never seen in a normal human thyroid a parafollicular cell, but by electron microscopy we are informed that these cells do indeed occur in humans, and they occur in greater abundance in pigs, and they're easy to see in pigs. But they are thought now to be the source of these medullary carcinomas of the thyroid. And these, of course, are the tumors which produce thyrocalcitonin. A typical field in a medullary cancer of rather uniform, undifferentiated cells. They have sort of a basaloid appearance. They may at times produce some follicles. And the one characteristic about them is that they elaborate this curious substance, amyloid. And this is one of the few tumors that occur in humans in which amyloid is elaborated by the parafollicular or tumor cell. Now, the last type in this classification is, of course, the anaplastic carcinoma. It occurs in a number of interesting histologic varieties. It really doesn't matter which one of those varieties you have, they're all terrible. And they produce very large, rapidly growing, bulky masses in the neck. There are no distinguishing gross characteristics except the size of the mass, by which you might make this diagnosis grossly. But certainly the clinical history would tell you that you have a highly malignant, highly anaplastic tumor. They have this totally anaplastic, dedifferentiated appearance, and they produce large, bulky masses. They early metastasize to the lymph nodes, and they early give rise to distant metastasis in bone and in lung. In terms of 10-year survivors, papillary carcinoma without implantation of the neoplasm in the soft tissues of the neck, or with metastasis in lung or bone, has a very excellent prognosis. Actually, these patients beneath the age of 45 really do just as well whether they had papillary carcinoma or whether they did not. When you have invasive recurrences or metastases, of course, the prognosis is materially reduced. Fortunately, in this group of patients, they are suppressible by thyroid feeding, and this has been a major breakthrough in the therapy of these patients. The follicular carcinomas, the encapsulated angioinvasives, if they are removed cleanly, do have a rather good prognosis. The invasives, on the other hand, do rather poorly. In our own statistics, I don't believe in recent times we have very many patients who have survived 10 years. Medullary carcinoma is a rather chronic form of cancer. Many of these patients will survive 10 years. Our own series, I think, is 54%. But many of these patients have and are living with disease. And if you follow them out for a longer period of time, this mortality considerably increases. The anaplastics seldom survive more than 6 months, really. When you find a patient who has survived for 5 years, it's usually a very unusual circumstance and rather the exception that proves the rule.
And now Dr. Kreil points out the indications for total thyroidectomy in thyroid carcinoma, beginning first with the indications in papillary carcinoma.
The great argument for total thyroidectomy arises from Texas, where they find multicentricity of the tumor if they make a lot of serial sections. Neither Dr. Beers or I pay much attention to this unless there is gross evidence, either of bilateral metastasis in papillary cancer or bilateral palpable gross tumor. Because we know, the Mayo Clinic study shows that 4% of just people in this room or walking up the street have microfoci of papillary cancer. It's very similar to the microcancers of the prostate in people over 50, where some 25% or more of them are shown to have these, but they don't develop clinically. And especially under thyroid suppression, they don't develop. And so we feel that it is not necessary to run the 13% or more risk of tetany that comes with total thyroidectomy unless there is clear evidence of bilateral disease, which of course occurs in 10 to 15% of the patients with papillary cancer, and you still will do some radical total thyroidectomies. But the number then, you get 15% tetany of 10% of all the patients, and that's quite a different thing than getting 15% incidence of tetany across the board. And tetany, as has been pointed out, is a serious disease. Now, in encapsulated angioinvasive carcinomas, as Dr. Hawk says, they not only don't metastasize to nodes, but they're not multicentric either. And so there's no indication for total thyroidectomy there. Medullary can be multicentric, that's all right. Actually, on the ones which are the anaplastic group, most of these we recognize clinically. They're such terrible things advancing with such rapidity and all that we almost always recognize them, needle biopsy them, and control them with cobalt helotherapy until such a time as the patient dies of his distant metastasis, which is usually only 3 or 4 months. Most of these people have a very rapid course, and cobalt controls it, whereas fungating recurrences, or if you get into big technical troubles with radical operations, fungation into the trachea through a tracheotomy stoma and all that, are terrible complications if you try surgical intervention. So I prefer to deal with these by needle biopsy and radiation. Lymphomas, of course, are very well dealt with by radiation, too. They're very radiosensitive, and a high proportion of these people are permanently cured by radiation.
Thank you, Dr. Hawk and Dr. Cryle. Dr. Oliver Beers returns to the microphone now to describe his technique of thyroidectomy, followed by Dr. Cryle's comments. Let's listen first to Dr. Beers.
First, intratracheal intubation. The operative site is exposed and the patient is placed in Trendelenburg, elevating the head. This may or may not control bleeding to some extent. I think probably it does. The only part of an operation that a patient sees is the incision. One must make a good collar incision, bilaterally equal unless the operation is to be extended into the lateral neck, and it must be straight across the neck and not obliquely across the neck. Otherwise, the cosmetic result is poor. The incision is carried down through the platysma, exactly through the platysma, because immediately below the platysma, in elevating your flaps under tension, one enters an avascular plane where the flaps can be elevated without bleeding, and rarely is it necessary to ligate any vessels. The avascular plane is incised slightly, and after you're once in it, you can complete the procedure under blunt dissection, which makes it rapid and very quick. As far as the strap muscles, one should separate the strap muscles exactly in the midline, and if the goiter has altered the midline, one can always identify it at the thyroid cartilage prominence or the suprasternal notch. Retraction. I've never seen a goiter large enough that can't be exposed by retracting widely on the strap muscles. It's so much quicker, safer, better exposure, easier dissection, less bleeding, and doesn't require the resuture of the strap muscles. Again, the tumor mass exposed. Once again, the tension on the tissues. Traction, tension, countertraction facilitates the operative procedure. Now then, once the thyroid gland has been exposed, the next point that I use is to transect the thyroid hemivessels to expose the trachea. This is sort of a carryover from the time when local anesthesia was used, and I wanted to expose the trachea so we could open it if we got into airway trouble. This is less important today. But anyway, the isthmus has to be isolated, so the trachea is exposed, and after that has been done, the pyramidal lobe is taken down, if one exists, and if a lesion grossly is not thought to be a cancer, the isthmus is transected. The thyroid lobe is grabbed by several cokers, elevated up out of the thyroid bed, under tension again, exposing the lateral or the middle thyroid vessels. These are divided, and then the next step is to, with pressure upward, and not always necessary, but very frequently, ligating the inferior thyroid artery in continuity. Now with tension, using the thumb, elevating the thyroid lobe up and out. One can identify this very carefully and identify just the vessel. If you get into bleeding, put your thumb or finger on it. This controls bleeding well. Never clamp without seeing what you're clamping for two reasons. One, the recurrent nerve, or the sympathetic nerve, which is down on the prevertebral fascia. This is reported to be a complication of thyroidectomy and shouldn't be. If you want to ligate the inferior thyroid artery, do it under full vision and with some tension, traction and countertraction on the tissues. It's easily identified. After that has been ligated, the next thing is to identify the nerve. It's easily seen. It's in a consistent position. At the point where the inferior thyroid vessel enters the thyroid lobe, the nerve either goes over the vessel, between the vessel, or deep to it. And with the thyroid tissues on some tension, with the thumb, the nerve is put on a little stretch, and actually you can take your instrument and rub across it, and it's sort of like a violin string. But you identify it, carry your identification to the thyroid vessels, and at this point the nerve then no longer goes up, but runs either in a parallel direction or slightly downward into the cricothyroid membrane and can be safely protected. Now then, at this point, the thyroid lobe is transected as a partial lobectomy in the lesion not thought to be a cancer. After the thyroid lobe is freely movable, one can pull the lobe down, feel the superior thyroid vessels under some tension, and place the clamps directly on the thyroid vessels, and they're transected. The lobe then is transected, leaving a small remnant of thyroid gland. Some cases, many clamps are used, and one should always put them on flat across the trachea, never down into the direction of the tracheoesophageal groove because of the risk of injury to the nerve. As far as parathyroid tissue is concerned, I always keep an eye open for it. But if I'm doing a subtotal or a partial lobectomy, I don't necessarily identify it. But if I see a parathyroid, I always preserve it. After this is done then, the superior vessels are suture ligated, and that suture then is carried down over the remnant of the thyroid gland, completing the procedure. The reason for attaching the remnants up to the thyroid gland, according to Dr. Pemberton's statement, which I always thought was good, was the fact that it at least brings the thyroid up in an organized position with the trachea to make it easier for the next surgeon that went back in for the recurrence. As far as closure, the strap muscles closed, and maybe another controversial point is drain. I've never seen a Penrose drain do any harm. 9 times out of 10, I think you could get by without it, but why not leave it in for 24 hours or 48 hours? I think it's a good safety valve, it's a good identification whether bleeding's occurring, and I think one is justified in doing it. Just in summary then, as far as what should be done for a lesion that is considered to be benign, grossly, because we have fresh frozen section pathology available, I would do a partial lobectomy. And then if the pathologist in 5 minutes reported that the lesion was a cancer, I would complete the procedure as a total lobectomy and do a subtotal or partial lobectomy on the opposite side to reduce the thyroid bulk to eliminate multicentric lesions if they're present. I'd do a total thyroidectomy only if both lobes were grossly involved by cancer. If the lesion proves to be benign, I would then be satisfied with my partial lobectomy on the one side. If it's a multinodular goiter, benign, then I would do a bilateral subtotal thyroidectomy. Barney,
I find myself in complete agreement with all of the basic principles that Dr. Beers has enunciated. We differ only in perhaps one or two things. I try to make transverse incision parallel to or in a natural wrinkle of the neck, because the more closely this incision follows that natural line, and I believe also the higher that the incision is placed, the less conspicuous it is. When the incision gets down over the clavicles, I think that when you hyperextend and make a low incision, there it is over the clavicles, and I think it's more conspicuous there. For years, I did exactly as you did with the strap muscles, and I agree that practically any goiter can be removed without dividing the strap muscles. But if you are going to do that, it means you have to raise the flap, and if you raise the flap, it means that there is more or less of a dead space, which is a temptation for serum to accumulate. And so about 10 or 15 years ago, we changed our basic technique, because most of our operations are unilateral, therefore an adenoma. And so we make a thyroidectomy incision that goes through the platysma and fascia. And then just on the side that we're operating on, we divide the strap muscles. This gives us a window into the neck, and the skin of the neck is much like the skin of a horse. It can be moved in almost any direction once you've got a window in it. So you take your window and retract it to accomplish your operation. Although it does require re-suture of the muscle, it's really very short, probably no longer than sewing up your divided strap muscles in that direction. And we feel it's a little bit simpler and perhaps gives a little bit better exposure, but these are minor details. Instead of dividing the gland to get mobilization, we generally go after the superior pole first, divide the superior pole, then rotate the gland and divide the isthmus last, because until we know the nature of the pathology and the whole thing, we can take any amount of gland we want as we go along in that way, rather than be committed to a half and so forth. The only other thing that I'd like to emphasize, and I believe you would agree, is that particularly in these people who are relatively young with nodular goiters in their 30s and 40s and so forth, at least 75% of these over a period of 20 years will have recurrent goiters if you don't give suppressive thyroid feeding. Because the same thing which caused the nodule to appear in one lobe is still acting on the other, and the vast majority of these will have recurrent goiters. And I'm still surprised always to see patients coming in who've been operated on really in recent years when this was known and available to the surgical profession, and see how few of them have been on thyroid. And of course, all of the recurrent goiters, except for cysts, can be avoided if 2 grains of thyroid is given daily as a routine after any surgery on the thyroid.
Thank you, Dr. Beers and Dr. Cryle. To conclude this program, here is Caldwell B. Esselstyn of the Cleveland Clinic's Department of General Surgery, turning our attention now to pathologic manifestations, techniques of diagnosis, and some operative considerations in hyperparathyroidism.
The pathology in any large series of patients with hyperparathyroidism that was reported over the last 20 years has by and large included about 80% adenomas, about 1% carcinomas, and about 18% hyperplasia. The further 1% of patients with primary hyperparathyroidism will have a non-parathyroid tumor form producing a parathormone-like substance. Now, I think that as our experience with this disease broadens and we become more and more compulsive about trying to identify all 4 glands, we're going to find more and more of these patients with hyperplasia. Now, the pathologic manifestations of primary hyperparathyroidism include the skeletal manifestations, which are demineralization, bone cysts, bony reabsorption, bowing, and occasionally pathologic fractures in the extreme form. The renal manifestations include the renal calculi, well known to all of you. In the advanced stages, there is nephrocalcinosis, and also there is epithelial damage, a secondary calcification, and eventually tubular necrosis in the advanced stage. The hypertension which one sees with hyperparathyroidism is not a direct effect of the parathormone, but rather is a secondary effect from the renal damage that has occurred. The mental symptoms include listlessness, depression, and confusion. The Muscular symptoms include hypotonia, hyporeflexia, and profound weakness. The gastrointestinal manifestations include a loss of appetite. Patients also will have increased constipation, an increased incidence of pancreatitis, and also an increased incidence of peptic ulcer disease. Dr. Oliver Cope from the Massachusetts General Hospital in 1966 reviewed their experience and was looking for the leading clue to diagnosis. Far and away, the majority of patients in 1966 in their institution were identified by renal calculi. This was followed by bone disease and peptic ulceration. Now, way down at the bottom of the list, second from the end, 2 cases identified by routine laboratory tests. We've gone over our own experience of 40 cases from January of '69 until February of this year, and found that 60% of those were identified by routine laboratory testing. I think that this is going to be a new era in hyperparathyroidism with detection of asymptomatic patients. Now, the techniques for diagnosis, actually the first 4 are just sort of included for completeness. I think that only when you have a very large lesion are you ever going to be able to feel this in the neck, or will it be seen displacing any structures in the mediastinum. The selenium methionine scanning has fallen pretty much by the wayside. It's only successful in about 50% of cases. I think the greatest hope lies ultimately with the parathormone immunoassay. But still, the most important test of all is the routine serum calcium, which guides us to further pursue a differential diagnosis of hypercalcemia in these patients. There's been a change since we reported last year a little bit on our technique. At that time, we were still going for the adenomas, and at that time we said you should probably spend no more than 10 minutes initially on one side of the neck before going to the other side, because the adenoma might be right there on the other side. I think we're going to have to spend a little more time on that first side now, because we think it's very important that all 4 parathyroid glands should be identified. The idea of saying it's simply one large gland and the rest are atrophic is no longer a sound practice. You cannot, at surgery, eyeball these glands and tell what the intrinsic pathology is or how biochemically active they are. So we make a point to get frozen sections, biopsies on all these that we can find at surgery, except for the large adenomas where we take them out entirely. We don't like to spill any large adenomas for fear they might be neoplastic lesion. The gland should be medially rotated so that one can look carefully on the back side of the gland, especially along the course of the inferior thyroid artery. The blood supply to both the superior and inferior parathyroid glands comes from the inferior thyroid artery, although the superior may occasionally receive a twig from the superior thyroid artery. Another favorite site is along the course of the laryngeal nerve and also within the tracheoesophageal groove. A word about the thymus. This has probably helped us more than anything else because of the knowledge of the common embryogenesis of the lower 2 parathyroid glands and the thymus, both sharing a common embryogenesis from the 3rd ultimobranchial pouch. And the vagaries of the lower ones are much more common than the upper glands. We have found that in 73 cases operated for primary hyperparathyroidism in the last 24 months, 1/4 of these we found a parathyroid gland, or indeed the adenoma, in or associated with the thymus. The thymus can be found by, usually there is a small fibrous strand coming down from the lowest pole of the thyroid gland. These strands or small vessels then lead right underneath the strap muscles to the superior mediastinum, and just by gently following these, one may then milk the thymus up out of the mediastinum. The characteristic appearance of the large adenomas in our hands has been reddish brown. The glands which are smaller and not as actively involved are usually yellow-brown.
And with Dr. Esselstyn's comments, we conclude another edition of Audio Digest Surgery, produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Until our next issue, Doctor, thank you for listening.